Evening.
Hello,
How are you?
I'm all right, thank you.
Good. All the other sessions have been uploaded successfully and shared, so that's all
Great.
good.
I'm still, there's been just this endless saga over payment that
Oh,
doesn't
really?
that doesn't seem quite over.
Oh,
Every
no.
time I think it's going to be over, it's never quite over.
Oh, sorry about that. Is that through our admin team?
Uh, yeah, it's become quite comical because the invoice that still waiting to be paid is one that I originally sent over a year ago.
Oh, no.
So the more recent, these sessions I've received payment for. It's the original sessions that
Oh, no.
I just got another email this morning that just made me laugh. It's like, could you resubmit the invoice? You're thinking, how many times have I resubmitted that invoice? We're still going.
No. Oh, dear.
I'm sure it'll happen someday.
Yeah, I'm sure it will. It's obviously in the system, but it is painful.
Yes,
Definitely.
I think it has now achieved the dubious prize of
Hello?
the longest time
Okay.
before payment of an invoice. Although
Yeah.
there was once I received payment for something that I then didn't
Hiya.
deliver for another 18 months. So that was the longest delay between
Hiya.
payment and
It's
delivering
Elaine
work.
again. Where transport is for Stephen Lloyd because I rang them
Oh,
and they said 20. Do you have an idea where transport is for Stephen Lloyd? Stephen Lloyd, it's Medina ringing again from West Florida.
okay. So I'm gonna go
So
mute
should I
myself.
start, do you think?
Yeah, I think so. Yeah,
Cool.
perfect. Thank you.
Okay, I'll sort out my slides. Oops. I was So we've reached session 4 out of 5. And in the previous session, I was providing an introduction to immunotherapy for cancer and explaining why it is that our white blood cells are able to detect and then destroy cancer cells. And I also introduced the checkpoint inhibitor group of immunotherapies. And I'm going to build on that session over the next hour or so. So in this section, I'm going to carry on from where I left off. So I'd explained how checkpoint inhibitors work, and I will give a very brief refresher of that right at the start of this session for anyone who can't remember or was missed or wants that little refresher. So I will refresh as to the mechanism of action of immune checkpoint inhibitors, and then I will discuss how we can use biomarkers, how we can use tests that we can perform on patient samples to predict who's going to be helped by these checkpoint inhibitor immunotherapies and who is better off not receiving them and possibly receiving something else instead. That will bring me to the end of the content about immune checkpoint inhibitors. And then for the final portion of this talk, I will describe a few of the other types of immunotherapy that are coming through clinical trials. So part 1 is about overcoming the limitations of checkpoint inhibitors through the use of biomarkers, and then part 2 will be about novel forms of immunotherapy. So as a quick refresher, the checkpoint proteins are a series of proteins that stick out from the surface of the T cell white blood cells. So the T cells are the form of white blood cell of our immune system that has the greatest capacity and potency and selectivity for killing cancer cells. And so these are often the target of immunotherapy, because if we can harness these natural abilities of T cells, they can form a really effective army of T cells to wipe out cancer cells. But this army of T cells has natural proteins on their surface that can mean they become suppressed. So these are the inhibitory checkpoint proteins, proteins that stick out from the surface of T cells. If they're triggered by a partner protein, then that T cell becomes suppressed. There are also stimulatory checkpoint proteins. If they are triggered by a partner protein, the T cell becomes more active. And what should happen is that T cells are activated in response to an infection or in response to cancer cells. Those T cells move into the site of the problem, whether that's an infected tissue, whether that's tumor tissue. They move into that site of problem. And as they enter into that environment, they put these inhibitory checkpoint proteins on their surface, which include PD-1. And then the presence of lots of activated T cells in a tissue sends out signals into that environment saying, there's lots of active T cells here. This could be a good thing. This could be a bad thing. And also, even if it is a good thing, these T cells are going to some point outstay their welcome. So when lots of activated T cells move into an environment, they send signals into that environment, which automatically triggers other cells nearby to put PD-L1 on their surface in preparation for when the T cell's work is done, so that T cell can be told to shut down and possibly even to self-destruct because its work is completed. So the mere presence of lots of activated T cells in a tissue automatically tells other cells to put PD-L1 on their surface, the trigger protein for PD-1, so that when the T cell's job is done, the tissue has a way of suppressing and forcing those T cells to die. And in a healthy body, the cells that are most likely to put PD-L1 on their surface are often other types of white blood cell, like the macrophages. But if lots of activated T cells move into a tumor, then it's not always just the white blood cells that put PD-L1 on their surface, it's also cancer cells that put PD-L1 on their surface. And this becomes part of the reason why the T cells don't kill the cancer cells, is because the T cells PD-1 is being triggered and they are being suppressed. The purpose of immune checkpoint inhibitors is to block the inhibitory checkpoint proteins such as PD-1, and therefore prevent the T cells from becoming suppressed. So checkpoint inhibitors that target a protein like PD-1, or perhaps they target PD-L1, they're trying to prevent the connection from taking place. Checkpoint inhibitors that work through this mechanism are boosting the activities of T cells that the body has already made. The body has realized, the immune system has realized that you have cancer cells in your body. Your immune system has created cancer-fighting T cells. Those cancer-fighting T cells have made their way into a tumor, and then they get stuck and they get suppressed because their PD-1 is being triggered. And you're reversing that suppression. What you haven't done is caused the immune system to create cancer-fighting T cells. You haven't told the immune system what a cancer cell looks like. You haven't educated the immune system. All you've done is reverse the suppression of T cells that already existed. And if the patient's cancer cells are hidden from their immune system and their body hasn't created cancer-fighting T cells, then this approach won't work for the patient. Because if your body doesn't realize, if your immune system doesn't realize that you have cancer, it won't have created cancer-fighting T cells, and there will be nothing for your checkpoint inhibitors to boost. You can't boost something that doesn't already exist. So you're reversing the suppression of T cells that already existed. You're not creating new T cells. The PD-1 and the PD-L1 targeted checkpoint inhibitors, they share a single mechanism of action. They are preventing PD-1 from connecting up with its trigger protein, PD-L1, and by preventing that connection, you're preventing the suppression of T cells. The CTLA-4 targeted checkpoint inhibitors have a slightly different mechanism of action because T cells put CTLA-4 on their surface as they are becoming activated rather than once they have already become activated. So you get a different effect with CTLA-4 targeted antibodies. You get an increased number of activated T cells in the body as a whole, whereas the PD-1 and the PD-L1 targeted antibodies, you get increased activity of T cells out in the peripheral tissues. Another impact of CTLA-4 targeted checkpoint inhibitors is that you reduce the number and reduce the activity of regulatory T cells, which is where, as far as we're concerned in this context, these are our enemies because regulatory T cells suppress cytotoxic cancer-killing T cells. We have lots of different immune checkpoint inhibitors, and the number is growing all the time, and there are tens more in the pipelines of various different drug companies. But all the PD-1 and PD-L1 antibodies have a single mechanism of action. They are preventing an interaction between PD-1 and PD-L1. We have no head-to-head trials between any of these antibodies. We have no reason to believe that any of them is any better than any other. So we can see them as a single treatment, albeit with lots of different names. Ipilimumab and tremelimumab, again, are two different versions of the same treatment. They are CTLA-4 targeted antibodies. Relatlimab is something slightly different. That's a LAG-3 targeted antibody. It is licensed as a treatment for melanoma skin cancer, but not for any other cancer. One way to try and improve the number of people who benefit from checkpoint inhibitors is to combine them with other treatments. And I'm going to start explaining how we might do that with this diagram. So in this diagram, what I'm trying to illustrate is that in different tumors, you find different numbers of T cells, different combinations and types of white.
Sorry, Elaine. We can't see any slides.
Oh no, I'm so sorry.
No worries. Just start now because you were going there recap, weren't you, from last time? So
I'll start again. I sorted out my slides on the screen and then failed to share them. If I ever do that again, please jump in sooner. Oh, it's so annoying. I'm so sorry about that. I will begin again more briefly. Okay, so apologies for that. Make sure I've got the chat. Sorry, I couldn't see the chat. Anyway, let me just move things around again. Everything is now all over the place on my screen. Okay, so I'll begin again with a very brief overview or a recap of how checkpoint inhibitors work. The checkpoint proteins sticking out from the surface of T cells, their purpose is for the body to be able to control its T cells and to protect us from autoimmune disease, protect us from chronic inflammation, things that could be caused by the overzealousness of our body's T cells. So on the surface of our T cells, in amongst all the different proteins that are there, some of them are the inhibitory checkpoint proteins. And when an activated T cell enters into a tissue, that tissue immediately prepares itself for when the T cell's job is done. And it does that by having cells which react to the presence of T cells by putting proteins like PD-L1 on their surface. So when an activated T cell enters into a tumor, the signals it's sending out automatically tell other cells in that environment to put PD-L1 on their surface. And when PD-L1 on the surface of a different cell type connects with PD-1 on the surface of the T cell, that connection causes the T cell to become suppressed. But what happens inside tumor environments is that rather, or as well as white blood cells having PD-L1 on their surface, cancer cells also have PD-L1 on their surface. And so any T cells that enter into that tumor environment quickly become suppressed. Some of them will even self-destruct because of PD-L1 connecting up with PD-1. By preventing that interaction from taking place by having a PD-1 or a PD-L1 targeted antibody, you are enabling more T cells to remain active. But importantly, what you haven't been able to do is teach the immune system how to react to cancer cells or how to generate cancer-fighting T cells. All you've done is reverse the suppression of T cells that already existed. If that person's cancer is hidden from their immune system, then there won't be any cancer-fighting T cells, and your checkpoint inhibitor isn't going to help that patient because you can't reverse the suppression of cells that simply don't exist to begin with. The PD-1 and the PD-L1 targeted antibodies, they increase the activity of T cells that are out and about in the body in peripheral tissues. The CTLA-4 targeted antibodies, they increase the number of activated T cells in the body as a whole, and they also reduce the number and activity of regulatory T cells. There's a whole lot of different PD-1 and PD-L1 targeted immune checkpoint inhibitors, but they are all targeting the same thing, the interaction between PD-1 and PD-L1. There's never been any head-to-head trials between these antibodies. There probably never will be any head-to-head trials. So as far as we know, they are all equally effective. They're all doing exactly the same thing. They're all essentially the same treatment. Ipilimumab and tremelimumab, they are CTLA-4 targeted antibodies. They're slightly different. And then relatlimab, at the moment only licensed as a treatment for melanoma skin cancer, that is different again. We can categorize tumors according to whether cancer-fighting T cells exist in those tumors. If they do exist, where are we finding them? What other white blood cells are found in the tumor environment? And scientists have tried to categorize this, hopefully in a useful way, talking about hot tumors, immune-suppressed tumors, immune-excluded tumors, and cold tumors. Now, this is their attempt to categorize things, and you need to bear in mind that a tumor can be more than one thing. Part of a tumor might be cold. There's no T cells there. The whole environment is very T cell suppressing. Another part of a tumor might be immune suppressed. There are T cells around, but they've been shut down by regulatory T cells, by myeloid-derived suppressor cells. Or there could be, in another part of a tumor, there are some T cells, but they're not able to get in amongst the cancer cells. We call that immune excluded. And in yet another part of a tumor, there might be a hot environment full of T cells. They're actively trying to kill cancer cells, but being suppressed through a variety of different mechanisms. So one tumor can be more than one thing. A metastasis might be different from a primary tumor. And this is all a sliding scale. Like there's no black and white, it's just scientists trying to, amongst all the chaos, amongst all the difference, trying to create descriptions or come up with descriptions that are helpful ways of thinking about and visualizing what goes on inside tumors. So the people, if your tumor or tumors are hot, full of cancer-fighting T cells that are being suppressed, you might, with your immune checkpoint inhibitors, be able to remove that suppression or reduce it, and the T cells can do more and they can kill more cancer cells, and that helps the patient. But if the person's tumor and any metastases are all very cold, there's no cancer-fighting T cells around, the immune system hasn't really reacted to the presence of their cancer cells, then it's very, very unlikely that they would be helped by immune checkpoint inhibitor therapy. The cancer where you're most likely to find a hot tumor environment is melanoma skin cancer. Melanoma skin cancer is caused by UV light from the sun. The cancer cells contain thousands of tiny mutations. They struggle to hide themselves in the immune system, and checkpoint inhibitor immunotherapy is likely to help the patient. But most tumors in most patients are not hot. And the purpose of using checkpoint inhibitor combination therapy is in the hopes of changing the immune microenvironment of people's tumors, hopefully increasing the number of T cells around and increasing the likelihood that checkpoint inhibitor immunotherapy will be helpful. One combination that has proven to be beneficial for some patients is to combine different types of immune checkpoint inhibitor. And the classic combination is to combine a CTLA-4 targeted checkpoint inhibitor with either a PD-1 or PD-L1 targeted checkpoint inhibitor. And this can be helpful. This is a classic clinical trial that was conducted quite a few years ago now in patients with melanoma skin cancer, showing that if you gave patients a combination of nivolumab and ipilimumab, patients did better overall than if you gave either just nivolumab or ipilimumab. I have to say, though, that since this trial was conducted, we do have a bit more nuance to this now, and we know that if a person's tumour is hot, is full of cancer-fighting T cells, where there is lots of PD-L1 around, then you don't need the second checkpoint inhibitor. Nivolumab is as good as it gets. The addition of ipilimumab on top isn't adding any benefit. The same goes in non-small cell lung cancer. If a person's tumor contains high levels of PD-L1, it's a hot tumor, then adding in ipilimumab to a PD-1 or a PD-L1 targeted immunotherapy isn't adding any extra benefit for the patient. But if you have a cold tumor, then the added ipilimumab is beneficial. Another combination that's been tested a lot is to combine chemotherapy with an immune checkpoint inhibitor. And there are lots of examples of clinical trials in which patients have been given a combination of a checkpoint inhibitor plus chemotherapy. This table lists 5 different clinical trials in which checkpoint inhibitors have been combined with chemotherapy. You can see with the response rates that the response rates for patients in the trial are much higher when you combine the two treatments together than if you give the checkpoint inhibitor on its own. And there is some benefit in terms of survival times. Another combination is to add together angiogenesis inhibitors, blood vessel targeted cancer treatments, and combine those with checkpoint inhibitor immunotherapy. The cancer where this has been most investigated is kidney cancer, a disease where usually angiogenesis inhibitors on their own are helpful, checkpoint inhibitor immunotherapy on its own is helpful. You combine the two together, you get better results than if you gave just one on its own. So sunitinib is a form of angiogenesis inhibitor, and in all of these trials, combining together a checkpoint inhibitor with a different angiogenesis inhibitor gave better results than the angiogenesis inhibitor alone. I think an important caveat to all of this is that the word synergy, the idea of two treatments enhancing one another's effects, it's a very appealing idea. It's an idea that gets talked about a lot. It's an idea that carries a lot of kind of psychological weight. We like the idea that the two treatments somehow synergize and interact and enhance how each other works. The reality, though, is that the clinical trials that have taken place, the results from those trials, it doesn't really look like synergy is happening. It looks like the two treatments are working independently of one another. And when you give the patient both treatments together, they get the benefit of one treatment added to the benefit of the other treatment. And that's what you see. We don't really see any evidence that they're enhancing one another's effects. There is scientific evidence that this can happen, that chemotherapy can create debris, that the immune system is activated by, that angiogenesis inhibitors can help T cells get out of blood vessels. There is scientific research that says these different treatments can enhance one another's effects, but the reality from trials, you're not really seeing that. The angiogenesis inhibitor helps some patients, the immunotherapy helps other patients. You combine all the data together and you see the combined benefit of both treatments. Another way of trying to get the best out of checkpoint inhibitors is to use biomarkers to help us to predict who they are going to work for. We can then give the checkpoint inhibitor just to the people most likely to benefit from them, and the people who would be very unlikely to benefit from them, we can hopefully be able to offer something different that would be effective for them. One biomarker, one way of predicting who is helped by immunotherapy with an immune checkpoint inhibitor is to measure PD-L1 levels. So PD-L1 is this protein that cells put on their surface in reaction to the presence of activated T cells. So it's a bit like a little flag waving saying T cells are here. And in virtually every clinical trial in which checkpoint inhibitors have been tested and where PD-L1 levels have been measured, in virtually every scenario, the higher the PD-L1 level, the more beneficial the treatment was for the patient. The reason why we only sometimes use PD-L1 as a biomarker and not all the time is that often there's no obvious threshold. There's no point at which you can say, well, PD-L1 levels are so low that nobody's going to be helped. Because even when PD-L1 levels are undetectable, the patient, oh, sorry, it's the second bar. So even when PD-L1 levels are undetectable, you often see that the patient is still better off with checkpoint inhibitor immunotherapy. In some clinical trials, it is possible to say, okay, we're going to set the threshold here. If PD-L1 levels are below this, there's no point giving the immunotherapy. If they're above that, there is point in giving the immunotherapy. But there have been plenty of trials where it's just not been obvious where that threshold should be set. And so we give the immune checkpoint inhibitor without mandating any PD-L1 test. And one of the issues we have with PD-L1 testing is that because it is a protein, it can come and go. It is something that cells put on their surface in reaction to the presence of activated T cells. But if those T cells disappear, then the PD-L1 will also disappear. So sometimes PD-L1, it may have been there when the biopsy was taken, but it's not there now because the T cells are no longer there. But it can be helpful. It can predict, or it can at least enrich the population of patients with those most likely to benefit from immunotherapy. Another complication though with PD-L1 is that sometimes cancer cells have it on their surface regardless of what T cells are there or not there, because the mutations the cancer cells contain automatically force them to put PD-L1 on their surface, and then if any T cells do wander into the environment, they immediately become suppressed. So there's a lot of imperfection, I guess, in trying to use PD-L1 levels to predict who is going to benefit from immune checkpoint inhibitors and who is not going to benefit. In some patients, high PD-L1 does predict benefit. In other patients, it doesn't. And as I've already alluded to, because PD-L1 is a protein, it can be made, it can be destroyed. Just because you found it in the biopsy that the patient that you took weeks ago, just because that biopsy had PD-L1 in it, doesn't mean there's PD-L1 there. It might have been that you biopsied an unusual part of their tumor where there was PD-L1, and actually in the rest of the tumor, there isn't PD-L1. It's just not an ideal biomarker. Another thing that you can measure that gives you some idea of whether checkpoint inhibitor immunotherapy might be useful is to measure the total number of mutations in the cancer cell's DNA. The more mutations the cancer cells contain, the more they struggle to hide themselves from the immune system, the more likely it is that cancer-fighting T cells exist that you can encourage and boost with your immune checkpoint inhibitor. So there is a rough correlation between mutation numbers and how much patients are helped by immune checkpoint inhibitor immunotherapy. It's not a perfect correlation. There are some cancers where the benefit is much greater than you would predict from the tumor mutation burden, like Merkel cell skin cancer. And there are some cancers where the degree of benefit from immune checkpoint inhibitors is much lower than you would predict from the tumor mutation burden, such as the majority of bowel cancers and pancreatic cancer. Even more confusingly, there's no correlation between PD-L1 levels and tumor mutation burden. A cancer can have a high tumor mutation burden and low PD-L1, or high PD-L1 and a low tumor mutation burden. They don't correlate with each other. In general, high PD-L1 levels correlate with a higher chance of response to immunotherapy, but not always. Sometimes you can set a threshold, sometimes you can't. And in general, a high tumor mutation burden correlates with a higher likelihood of benefit from immunotherapy, but not always. And if you used PD-L1 and tumor mutation burden to select patients to receive checkpoint inhibitors, you would identify two different groups of patients. There'd be a bit of overlap, but probably a lot, not a lot, but both groups of patients you've identified have a reasonable chance of benefiting. A biomarker that is a better predictor of response to checkpoint inhibitor immunotherapy is microsatellite instability. Microsatellite instability is a pattern of mutations created when a cell loses the capacity to perform a DNA repair process called mismatch repair. So if cells have a problem with DNA repair, they accumulate thousands of mutations in a particular pattern, which is what we've called microsatellite instability. If a person's cancer exhibits microsatellite instability, there's a very good likelihood that they'll be helped by checkpoint inhibitor immunotherapy. And in this chart, you can see roughly the proportion of various different cancer types where you're likely to find MSI. So endometrial cancer, colorectal cancer, stomach cancer, cervical cancer, these are the cancers where you're most likely to find MSI. And in addition to that, it does look like there are things we can do that would help patients prepare to receive immunotherapy. We know that as soon as somebody who's a smoker stops smoking, their immune system starts to recover and they're more likely to benefit from immunotherapy. Physical exercise can rebalance the immune system. It reduces inflammation, it encourages the T cells. Again, it helps with immunotherapy. Some of the other things that seem to help via their impact on the digestive system. The more fiber we eat, the less inflamed the gut becomes. And again, that seems to rebalance the immune system, reduces inflammation, and helps the T cells. And some of the treatments that are given to cancer patients, such as antibiotics, various painkillers, steroids. All of these, again, have an impact on those T cells and can reduce the benefit of immunotherapy. So these things are worth bearing in mind when somebody is likely to receive immunotherapy, that there are things we can do to help their immune system and help their T cells and potentially improve the opportunity or improve the chance that immunotherapy will help them. So the second section of this talk is about novel immunotherapies, going beyond immune checkpoint inhibitors and having a look at what other immunotherapies are out there. And I'm focusing my attention on immunotherapies for solid tumors. There's a whole different group of immunotherapies that are useful for hematological cancers. So I'll start here with oncolytic viruses. These treatments have been around for decades, and there are quite a few of them licensed as treatments in China and Southeast Asia. They haven't really taken off here in the same way. We've been less convinced by this group of treatments. The idea with oncolytic viruses is that you inject this altered virus into somebody's tumor, into their metastases, and this virus, the way you've altered it, improves its ability to infect and multiply inside cancer cells and burst them open and cause them to die. Healthy cells have more protections and so should be less vulnerable to infection by the oncolytic virus. So the oncolytic virus selectively, preferentially infects and kills cancer cells. That in itself doesn't really help the patient. You never kill enough cancer cells for that to be beneficial, but the debris you create is helpful. The debris created attracts in and activates the dendritic cells. Those dendritic cells start hoovering up that debris, they process it, they display it on their surface to T cells and lymph nodes, they activate T cells, and hopefully those T cells start infiltrating in amongst the cancer cells and start destroying those cancer cells. There have been many trials with many different oncolytic viruses, but at the moment, only one of them has been approved, and it's not yet widely used because there's lots of issues around manufacture and distribution. There's lots of obstacles to overcome, but oh, sorry, I'm thinking about other viruses in my head. This particular one, they have overcome those obstacles, and so T-VEC Immunogic is NICE approved for melanoma skin cancer, but the obstacle is that it's only a very specific group of patients who would be eligible for this treatment. If you have metastatic melanoma and widely distributed metastases, this isn't for you because they have to be able to inject the virus into every metastases that they can detect in order for it to be beneficial. And if you didn't have any metastases at all, you'd be treated as having early stage melanoma and you'd most likely receive surgery. So it's a very specific group of patients who can receive this treatment. You have metastatic melanoma, but any metastases that have been detected are accessible and injectable with this oncolytic virus. Another approach that has proved to be beneficial in melanoma, but not yet widely used, is tumor infiltrating lymphocytes. Tumor infiltrating lymphocytes is a form of cellular therapy. This is where you're using living cells as a cancer treatment. You're using the patient's own cells, so it's considered an autologous treatment. If you were using a donor's cells, it would be an allogeneic treatment. Most cellular immunotherapies involve T cells, but there are some that involve other cell types. In some forms of cellular therapy, those T cells are modified first, but not always. And often, in order to give the treatment a fighting chance of success, you give chemotherapy prior to giving the cells so that you've reduced cancer cell numbers as far as you can. Another important aspect of cellular immunotherapy is that often it's a tailor-made treatment for each individual patient involving their own T cells. So there is quite a long delay between collecting the T cells and then being ready for infusion into the patient. It can take a month or more to prepare the T cells, during which time you've got to try and keep the patient as stable and as well as possible so that they are fit enough to receive that treatment. So tumor infiltrating lymphocyte therapy is where you surgically remove one or more tumors. These are physically sliced up into tiny little pieces and passed through a strainer so that individual cells can then be grown in the laboratory. And you grow the cells in the presence of a molecule called interleukin-2. It encourages the T cells, but only the T cells. So other cells die off and you end up just with T cells. Those T cells are multiplied. You try and give them an extra boost, make them really healthy, make them really lively, and then you infuse them back into the patient's blood. This treatment can work for patients, particularly with melanoma skin cancer. There is a long delay between taking the T cells and then being ready to give back to the patients. It's usually about 6 to 8 weeks. You need to give conditioning chemotherapy before they receive their T cells to give those T cells the highest chance of success. And at the moment, we only have this one clinical trial where it has proved to be a beneficial treatment. This was a trial done in the Netherlands, and there are now challenges of how you scale up this treatment, how you make it accessible and deliverable in a national health service. CAR T cell therapy and TCR engineered T cell therapy has a lot of similarities with the tumor infiltrating lymphocyte therapy. With the TILs, you take tumor, you chop it up, you pass it through a sieve, you purify just the T cells, you put those T cells back into the body. The difference between tumor infiltrating T cell therapy and CAR T cell therapy and TCR engineered T cell therapy is that you take T cells directly from the blood and you genetically modify them. For CAR T cell therapy, you give the cells an extra gene known as a CAR gene. For TCR engineered T cell therapy, you give the T cells an extra T cell receptor or TCR gene, and then you infuse the T cells back into the body. So you've genetically modified the patient's T cells before you give them back to them. CAR T cell therapy is where you add in a gene called a CAR gene to the T cells' chromosomes. That forces them to produce a protein called a CAR protein. And that CAR protein is a mix and match protein. It's known as a chimeric antigen receptor. Chimeric means bits and pieces of different things. So that CAR protein is part antibody, part bits and pieces of various T cell proteins. And T cells, if you give them a CAR protein, they will then be able to react to the presence of a cell surface protein on the person's cancer cells. So you've switched the target of the natural T cells. Natural T cells don't connect with intact proteins. You've actually made the protein on the surface of the T cells look a lot more like an antibody than a T cell receptor. So you're trying to change the T cells so that their natural target changes to be something naturally found on the surface of the patient's cancer cells. TCR engineered T cells are different because the new gene, the new protein that these modified T cells make, is a natural T cell receptor. It's just a natural receptor that targets something that T cell wouldn't normally target. But the normal target of a T cell is a tiny fragment of a protein held out in an MHC cup on the surface of another cell. It's something I described in the last presentation. So the natural target for T cell is a tiny protein fragment nestled inside an MHC cup. TCR engineered T cells, you've just changed what protein fragment the T cell reacts to. There are some advantages for TCR engineered T cells over CAR T cells when you're trying to create a treatment for somebody with a solid tumor. With hematological cancers, CAR T cell therapy has been very effective. But with the solid tumors, there are a lot more obstacles that so far have prevented us from creating any really effective CAR T cell therapies for solid tumors. One of the limitations of CAR T cell therapy is that the target has to be something found naturally on the surface of the patient's cancer cells. And with the solid tumors, it's much harder to find suitable targets. With TCR engineered T cell therapy, your target is a tiny protein fragment. You've got a lot more different possible targets to choose from. There are also advantages in the terms of the safety of the treatment. The CAR protein is a weird mix and match protein. It's hard to control CAR T cells. TCR engineered T cells, you've just switched their target from one protein fragment to a different protein fragment, but the whole connection between the receptor and its target looks more like a natural connection. The T cell activation is more orderly, more controlled, more like normal. And so the whole process of the T cell becoming activated and destroying target cells, it's more orderly, it's longer lasting, there's less chance of severe side effects. There are various different targets that are being explored as targets for TCR engineered T cell therapy. As I said, they're all tiny little fragments of proteins. Sometimes they're exploring fragments of mutated proteins made only by cancer cells, fragments of virus proteins made by virus-infected cells. There are also some proteins known as cancer testis antigens or cancer germline antigens. These are proteins not normally made by adult cells, but sometimes cancer cells start making them. They're really trying to explore any way of creating TCR engineered T cells that will target cancer cells exclusively and not target healthy cells. So there are advantages of TCR engineered T cells in terms of safety, in terms of the range of targets you can go after. One of the limitations, though, of TCR engineered T cells or any cancer treatment where you're using T cell receptors for targeting, if you use a T cell receptor for targeting, you have to perform HLA matching. All of us vary in terms of the range of MHC cups on the surface of our cells, and different MHC cups are more common in Asian people, in Caucasian people, in people from indigenous populations in Australia. There's all sorts of different cups found in different human populations in different amounts. And each cup can only display a certain range of protein fragments, peptide antigens. So if you're using a T cell receptor for targeting, you need to make sure that that T cell receptor is targeting a protein fragment that the person's cancer cells might possibly display on their surface. So you have to perform HLA matching to make sure there's even the chance that their MHC cups are displaying the fragments that your treatment recognizes. The first ever approval of TCR engineered T cell therapy is a treatment that often gets abbreviated to afami-cel. And this is a treatment, it is TCR engineered T cell therapy, and you take the person's T cells, you give them a new T cell receptor gene, they make a new T cell receptor protein, and that new T cell receptor protein recognizes a tiny fragment of a protein called MAGE-A4. That tiny fragment is only 9 amino acids long, and it gets called MAGE-A4 230 to 239. Those are the 9 amino acids that the new T cell receptor recognizes. The trial that led to the approval of afami-cel is a very small trial. The patients who took part in the trial, they were first of all screened to make sure that there was a possibility of their MHC cups on the cancer cells displaying that little fragment of MAGE-A4. So you had to check that the right cup was present, HLA-A02, and that the cells were making MAGE-A4. So out of 373 patients screened, only about 30% of those patients had the right MHC cup and the cells were producing MAGE-A4. Another way of activating T cells and engaging T cells and persuading T cells to kill cancer cells is through the use of T cell engagers. T cell engagers are little double-ended proteins that attach to a cancer cell with one end and a T cell with the other end, and they bring the two together. Some of these T cell engagers take two tips from two different antibodies and connect them together, but the only one of these T cell engagers licensed for a solid tumor is one where it's a slightly different structure. They've taken the tip of a T cell receptor and they've taken the tip of an antibody and they've linked them back to back. The tip of the T cell receptor connects with a little protein fragment. The tip of the antibody connects with a protein called CD3 found on T cells, and you're trying to create a physical connection between the T cell and the cancer cell and persuade the T cell to kill the cancer cell. The only one of these treatments that is a licensed treatment for a solid tumor is a treatment called tebentafusp. Tebentafusp attaches to CD3 with the antibody part, and it attaches to a fragment of a protein called GP100 with the T cell receptor part. And that fragment of GP100 is sometimes present on melanoma cells. It's sometimes found on melanoma skin cancer cells. It's also sometimes found on uveal melanoma cells. Uveal melanoma is the most common form of cancer that occurs in the eye. And it's an aggressive form of melanoma, and it's a form of melanoma where we have very few effective treatments if that cancer spreads. So this was the form of cancer in which tebentafusp was tested. It could potentially help people with melanoma skin cancer as well, but the first phase 3 trial was conducted in patients with uveal melanoma rather than cutaneous melanoma. And again, they performed HLA matching, tissue matching, to check that the patient's MHC cups could potentially display that little fragment of the GP100 protein recognized by the treatment. And then the very last treatment I'm going to mention is treatment vaccines. And I'm going to mention a very sophisticated form of treatment vaccine where you actually create an individual vaccine for each cancer patient through a thorough investigation of their cancer cells and the mutations found in those cancer cells. So these are individualized neoantigen therapies. And how it works is you take cancer cells from the patient's body and you compare and contrast the mutations found in the person's cancer cells and the natural genetic makeup of the patient as determined by analysing their normal white blood cells. Apologies for the dog going nuts in the background. So you extract DNA from the person's cancer cells, you extract DNA from healthy white blood cells, and you compare the two. And you identify mutations that exist in all of their cancer cells and none of their healthy cells. And using that information, you work backwards and you work out you sort of work forwards and backwards in a way. I'm tying myself in knots. So you work out from the mutations you've identified what protein fragments are made from those mutated bits of DNA. And having worked out what the protein fragments look like, you then design an mRNA strand that encodes for those protein fragments. You could use a DNA strand coding for the protein fragments, but it's usually an mRNA strand. So you design a strand of mRNA containing the instructions for the protein fragments that you believe are on the person's cancer cells based on predictions you've made from the mutations you found in the cancer cell's DNA. So you've taken your predictions and you've designed a piece of mRNA. And that mRNA is going to be very, very fragile because mRNA is very fragile. So you wrap it up inside what are called lipid nanoparticles. So tiny little fatty spheres that contain the mRNA that protect the mRNA and stabilize it so that in the body, what hopefully happens is dendritic cells pick up those nanoparticles. They take in the mRNA. From that mRNA, they make a bunch of protein fragments, display them in their MHC cups, and persuade T cells to react. So it's really complicated. It's taken many, many years for scientists to try and figure out from the mutations you find in a person's cancer cells, what protein fragments are going to be in their MHC cups. How did you design a strand of mRNA, which then forces dendritic cells to make those protein fragments, show them to T cells, and activate a whole bunch of T cells? It is not a strategy that's going to cure patients with metastatic cancer. It is far too inefficient. You just don't get enough T cells to cure a person of metastatic cancer. But what you potentially can do is give a vaccine like this post-surgery and prevent the person's cancer from ever coming back. Now, we're still waiting to see if this really does work, because at the moment, we only have results from relatively small trials, such as this one, which involved about 150 patients. In this trial, it did look like the vaccine strategy was helping, but the phase 3 trials that are currently ongoing, I believe in melanoma skin cancer, non-small cell lung cancer, and kidney cancer, when we get those results from those phase 3 trials, that will tell us whether this strategy really works. In the first half of this presentation, my focus was on the immune checkpoint inhibitor immunotherapies. How can we improve on the results we've had so far? Is there a way of combining immune checkpoint inhibitors with other treatments where you boost the number of patients who benefit from those immune checkpoint inhibitors? Are there ways of selecting the patients more carefully to receive them so that we're only giving them to the patients most likely to benefit? So far, I would say our success has been a bit mixed. We do have combinations that are licensed for cancer patients. We probably haven't achieved this kind of nirvana that we're searching for, where the two treatments synergize and enhance one another's impacts. What we're probably doing is just getting the additive benefits of two treatments combined together. With the biomarkers, we definitely have improved things for some patients. We can identify some patients, particularly through MSI testing, we can identify patients likely to benefit from immune checkpoint inhibitors. But aside from MSI, using PD-L1 levels to select patients, using high tumor mutation burden to select patients, they're partly useful. They're not perfect biomarkers. Sometimes it's helpful to use them to select patients, sometimes it's not. And then hot on the heels of the immune checkpoint inhibitors are a lot of other novel immunotherapies. We have oncolytic viruses, we have tumor infiltrating lymphocyte therapy, we have CAR T cell therapy, TCR engineered T cell therapy, T cell engagers, treatment vaccines. There's a whole raft of immunotherapies being explored as treatments for people with solid tumors. There's a long way to go for many of these treatments before they will become part of our standard way of treating solid tumors. There's always progress at every conference I attend. You can see the progress being made. You can see us inching forward, but there's a way to go. Okay, I will stop showing my slides there. And I can only apologize again for the beginning where I forgot to share them with you. I do apologize for that.
Thanks, Elaine. Don't worry. It's fine. I can
Too many moving parts.
Yeah, definitely. Thank you. That was great. There's so much going on, isn't there? It's so interesting.
Oh, so much. And I was going through those slides and thinking, I'm going to have to add in some new slides as well. There's so much happening with bispecific and trispecific antibodies, creating antibodies where one end activates T cells, the other end attaches to a different cell surface protein on the cancer cells, or it targets the blood vessels. Like doing more than one thing with an antibody is really taking off at the moment. Like rather than combining antibodies together, creating these dual targeted and triple targeted antibodies that do more than one thing at a time. There's just so many of them coming through. How to decide which ones to include in slides or not, because none of them have proven yet. You sort of see them approaching like a wave of just hundreds of clinical trials testing them out. It's impossible to predict which ones will work and which ones won't. You just sort of see this wave of treatments coming at you.
It's obviously a big area though, so with all that coming out, hopefully some really good results will come out of that. So yeah, exciting times.
Yeah, I think I find with I've been around a while now, and you see these waves of treatment sort of arrive and then settle in. Around the year, sort of the late 1990s, early 2000s, it was the targeted therapies. We were suddenly inundated with them, and some of them worked and some of them didn't. And it took a while to work out which to give patients for what reason, for what cancer, what was going to work and what didn't. And then there was a lull where people got a bit despondent about the targeted therapies because resistance is such an issue. And sort of between probably about 2005 and 2012, it didn't feel like there was a huge amount of new stuff happening. And then the immune checkpoint inhibitors arrived, sort of 2011, 2012 through to 2020, was just this wave of clinical trials and excitement around the immune checkpoint inhibitors. And then again, there's a bit of despondency that sets in. We realize so many people's tumors are not hot. They're not candidates for immune checkpoint inhibitors. It's really not going to work for them despite our best efforts. And so from sort of 2020 to 2025, again, it felt like there was a lull. People getting sort of like settling in with the immune checkpoint inhibitors. We're using them a lot. They help some patients. They're really useful, but they're not the panacea. They don't work for everybody. And you get the sort of collective sigh of when it works for some, it doesn't work for all. And now it feels like the momentum is building again of all these new immunotherapies, and particularly the antibody drug conjugates, the bi and tri-specific antibodies. You can see this new wave of treatments approaching, And again, it's going to take a lot of working out. Who do they work for? How beneficial are they? Which tumor types, which patient settings are they going to be beneficial for? And you just sort of feel that momentum coming again of the next wave of treatments being about to hit, that will again change the way we approach cancer treatment. They're not quite here yet. I think for the last half a dozen years or so, there's been a bit of a lull in terms of new stuff coming along, and now the momentum's building again. I've been around a long time.
So have I, but I've seen the turnaround with melanoma though. I mean, that has just been revolutionizing. You know, seeing what patients used to go through back when I started 30 years ago to now, it's amazing. So if that can happen to some more tumor sites, then that will just be fantastic, won't it?
Yeah.
Okay, so we've just got one more left with you, I think. Is that right?
Yes. Sort of precision cancer medicine next time, which I think is useful for bringing together quite a lot of different strands in terms of targeted therapy and immunotherapy, and how you get the best out of these treatments for individual patients.
Yeah, brilliant. That's on the 28th. So that's great. Thank you so much for your time.
Okay. Thank
you. Your knowledge. It's been brilliant. Thank you. See you soon. Take care.
Okay. Bye.
Thank you.
Bye.